Dialogue with a Doctor, featuring Southwest Florida's leading physicians.
Hello and welcome to Dialogue with a Doctor. This is a show where we interview local physicians about their craft or their product. Today we're talking about craft with Dr. E.Eichten. He's a practicing orthopedic surgeon here in Naples, Florida. He also practices in Fort Myers. And we will be talking about hip replacement surgery, how it's done, why it's done, who gets it done. But first, we want to talk about you and learn a little bit about you, where you came from and how you got here.
Well, thanks for having me again. Appreciate the time. So I grew up in Minnesota, and then I progressively, as my training went further along, I moved further and further south, because I realized that there are places warmer than Minnesota. So I did go to Kansas City for medical school, and then Dayton, Ohio is where I did my residency training. And then I did do a joint fellowship. That's an extra year of just hip and knee replacements, where we did almost 1,000 joints that year. So I got to see a lot, do a lot, and kind of honed in everything regarding hip and knee replacement.
And then how did you end up in Naples?
Ended up in Naples. Our practice has been expanding. We've added surgeons. I'm with Joint Implant Surgeons of Florida. And we expanded to the Naples office. We're on Immokalee Road, just a short drive from here. And we also have an office up on College Parkway in Fort Myers. And originally, in my third and fourth year of medical school, they had options to do rotations down here. As part of the Kansas City school, they send about 10 students down. And that's how I kind of became familiar with the area. And I learned a lot in my medical school here. And that's how I met the partners in my current practice. So they invited me to come back as soon as I got done with residency, which everything kind of worked out as planned, and that's what I did.
I guess once you live down here for a little while from the north, you don't want to
You get a little bit of a taste of everything down here.
So let's talk about hip replacement surgery. Who would be getting hip replacement surgery and why? So
most patients that require a hip replacement have severe arthritis of the joint. That's most common. Arthritis means that the cartilage and the smooth surface that's in the hip joint has kind of worn out. That's where the term bone on bone comes from. The socket side is worn out, and the femoral head side is worn out. And once that's worn out, it's hard to replace that, and it's very painful when the patient walks or in certain motions. And as the patient kind of declines in their function and their pain increases and some of the non-operative stuff isn't working, those patients kind of move on to the next step, which is a hip replacement.
So are there other reasons besides osteoarthritis for people needing a hip replacement? Yeah,
so some patients have congenital deformities, which means that they had it from birth or when they were a child, and those sometimes develop into arthritis. You could also have damage to that joint, car accident or something that damaged the hip, and we call that post-traumatic arthritis. And another cause, patients who have been on steroids for different reasons, sometimes they get avascular necrosis. And that's not actually a problem with the cartilage, it's more a problem with the bone. The bone actually loses its blood supply, and then the cartilage kind of collapses on top of that. So that's another reason for needing a hip replacement.
Well, I imagine in Southwest Florida there are plenty of patients, because we have people who are aging here that need joint replacements.
Yeah, and the numbers that are projected for the baby boomers and everybody that's aging, the hip replacements needed is going to get really ramped up over the next 10 to 15 years.
So what age groups do you generally see getting hip replacements, just in general?
In general, it's usually Medicare age, 50, 60, 70, around that age. We also do hip replacements for patients who have falls. If they break the bone in a certain area, the correct treatment is a hip replacement, and that gets them to recover the quickest. So those patients are 80, 90s that we see that a lot too.
That's where the bone won't heal or grow back?
So if a fracture, you break right below the ball, and you lose the blood supply to the ball, and that's why you have to replace it. So if the fracture hasn't moved, you can fix it with screws, If it shifts or you lose the blood supply, then you're better off just doing the hip replacement. They recover a lot quicker.
So then, before resorting, if you let me use that word, to
Sure.
surgery, what can you do to defray that surgery?
So a lot of stuff that you can do non-operatively. One would be a cortisone injection, which is an anti-inflammatory, and we can put that right into the joint under ultrasound in our office. And that helps with the pain. It's just a matter of how long it lasts. Some patients, it only lasts 2 weeks. Some patients come in once a year for their injection. So the hip takes a lot of weight, and the injections for things that we'd use for the knee don't work as good on the hip, but there are options. That would be platelet-rich plasma. You could try stem cells depending on how bad the arthritis is, or some of the new regenerative medicine. If the hip is completely worn out, it's probably not worth the cost to try some of that, because patients do very well with hip replacements.
So I have patients that get a cortisone shot in the hip and come to see me, and it lasted 3 weeks, and they want to go back for the next one. Is it that if they failed the first one, it's just not going to work, or how does that work?
You can try another one. It depends on the patient's situation. Some patients have other things going on. They want to prolong the surgery until next year or whatnot. So you can try another injection. You just don't want to do too many per year, usually about 3 to 4. So if you can space them out 3 months, that's safe to do. If you start doing too many cortisone injections, then it can damage the tissue around the hip. The other thing too that patients can do is modify their activities. Some patients are marathon runners. If they switch to swimming or cycling, sometimes they can get by a little bit longer without having to replace the hip.
So I think there's many patients ask me about how this is done, or at least how do you approach it? Should they do the anterior or traditional, or can you tell us a little bit about the differences between these things?
Yeah, so just from experience from my training, and I've kind of transitioned now, I just do everything anterior. There's a couple different anterior approaches. So traditionally, if you have any approach and it's done correctly and the parts are put in correctly, most patients are going to do okay. You want to avoid the complications with the posterior approach would be a dislocation. So when you go into the hip, you cut all the tissue that's behind the femur to get to the hip. Most surgeons will repair that tissue, but sometimes it doesn't heal very good. So if you get into a certain positions where you bend down too far, sometimes the hip can actually dislocate, and that would be, if you look at the hip joint, this is a hip replacement, the hip can actually fall out of the socket. So that's it doesn't happen very often, but it happens a lot more frequently with the posterior approach. So that's getting to the hip from behind. So I do come in the front of the hip, and there's two different ways to get to the hip in the front. One is a direct anterior approach, and one is what we call anterior lateral. The anterior lateral is an approach I prefer because it's the most stable the hip can get.
So anterior is up front and lateral is over here.
So lateral is just in the front of the femur. So your incision's still on the side, but you sneak right in here.
Oh, I see.
So if you go in the front, there's a nerve that can cause numbness and tingling in the front. The benefit to going directly anterior is you split through the muscles. The anterior lateral, traditionally you would take off some of the muscle here. Now we've got it down to, we're just taking a sliver of muscle. It's about 10%, and we repair that. So everything that was there beforehand is repaired and looks exactly the same after. The difference between coming in the back and the front is the tissue heals a lot better in the front. So we repair the capsule, and we repair all the muscles that are split through to get to the hip joint.
So how do you decide which anterior approach to do? Is there a reason why you do one versus the other?
Yeah, so the direct anterior, if you look at the literature, there's still a little bit higher risk for the patient, and that could be getting the femur in is very difficult. So some of the newer studies have shown that the posterior and the direct anterior have the same dislocation rate. So the complications are a little bit too high for me to switch my whole practice to direct anterior. And that has to do with getting to the femur. So if you release all the tissue front and back so that you can access the femur, then you're essentially doing a posterior approach from the front. So that if you have a surgeon that does a ton of them, they're probably not doing that because they have the experience. I think the issue comes when a surgeon that doesn't do a lot of them tries to do them, then the complications are higher. So right now, if you actually pull the literature, the complications for direct anterior is a little bit higher than anterior lateral.
So you're using the anterior lateral
Yeah.
approach
Yes.
primarily?
Yes.
Interesting. So what is the procedure like for the patients? What prep do they need, and how are things done?
So the basic prep is making sure that you're healthy for surgery. So that's done by seeing a physician, medical physician beforehand. Sometimes the patient needs to see a cardiologist. We want everything to be safe. You have a new hip, but you have a heart attack, then that's not good either. So we make sure everybody's safe before we do the surgery. It's a small incision. Patients right now, most of them are going home the next day. I think over the next 3 to 4 years, there's going to be a transition where a lot of the hip replacements are going to be done outpatient. It's kind of leaning that way in the rest of the country. So the pain's different when you wake up from surgery. You go from having bone on bone, and then you have a smooth joint. So if you look at the surface of the joint, it's either metal and plastic or ceramic and plastic. It becomes very smooth. So the patients notice that right away, and they feel a lot better. The soreness comes from doing the procedure, repairing the capsule and things like that. That's a little bit painful. The other thing that takes a little bit longer to recover is, right now we're not using any cement for hip replacement. So all the implants are what we call press fit. So they fit perfectly in each femur that we do, and the surface on the titanium the bone will actually grow onto it. So it looks kind of like bone. So once it grows onto that, the only reason I bring that up is that it takes about 6 weeks for that to happen. So that's what I kind of do my cutoff for patients. They ask me how long it's going to take them to recover. Patients are doing very good in the beginning, and then about 4 to 6 weeks, you're recovered.
So you do physical therapy, you provide physical therapy in your offices afterwards?
Yes, we have physical therapy in our office. Sometimes it's hard for the patients to get in a car or come to the office 3 times a week. So in the first week or so, you can have a home health company come to your house. They'll do the therapy at your house. Once you're safe getting in and out of the car, then you can come to the office and do your physical therapy.
How long do they do physical therapy?
It's usually about 4 weeks, sometimes 6 weeks, depending on how the patient's doing.
So from your point of view, for what you do, you're managing the patient for maybe 3 or 4 weeks or 6 weeks after surgery. But what do they expect after that? They'll still have some stiffness. When does it get to the point where they're mature, so to speak?
Usually at about 6 weeks, the patients are doing very good. By 3 months, they're doing really good. By a year, they don't know they had their hip done. So that's kind of the progression.
That's pretty amazing. So what kind of products do you use? I know there are different implants.
Yeah, there's a lot of different companies. One is Zimmer Biomet, and they have a very good polyethylene and a very good ceramic. So that's kind of the best surface as far as longevity. So we want these things, if somebody's 50 or 60, we want them to last 30 or 40 years. So they never have to have it done again. And that's what the engineers say with the newer polyethylenes. That's the liner.
30, 40?
They say 200 years that it'll last. But that's based on simulation in the lab. Obviously, we've had problems in the past with metal on metal, certain surfaces. But there is about 20-year data with very low wear rate with the ceramic on a polyethylene.
Can you show us where, when you say ceramic,
Sure.
for our viewers, where that is?
So when you do the socket, it's titanium, and then you put an insert in there. That's the polyethylene. So now companies are putting vitamin E in there. And we do have a hip that we designed. It's called Next Step Orthopedics, and it was just FDA approved. So within probably the end of the year or next year, we will be implanting those. And the difference with that polyethylene is that it's made in small batches. So when we look at it in the lab, when they do their machines that kind of cycle it, there was very little wear in that, after 5 million cycles or 10 million cycles. So it's a very good polyethylene, and that's kind of the future. We've kind of made a hip design that, we took the best of all the companies that we're familiar with. So.
And can you show where
Let me
the...
take this out.
Thank you.
So this is the actual hip replacement. So on this side, this goes inside the femur bone. It's titanium. And this is a rough surface here, so that's where the bone will grow onto it. And then for the heads have different sizes. They also have different lengths. So it's very important, I think, with the posterior approach, surgeons would make the legs a little bit longer to make them more stable. So then the patients wake up with a longer leg, and they don't like that. So with the anterior lateral, you don't have to worry about that, and then it's very stable too.
Well, things are getting better and better and better. It's really quite amazing to think about the fact that somebody would have outpatient surgery for a hip.
Right.
That's pretty cool. Well, we'd like to thank you, for coming and talking to us about hip replacement surgery and the Biomet Zimmer product and all about what you do. We've learned quite a bit, and we want to have you back on the show again as well.
I appreciate it. Thank you very much.
Appreciate it. So we'd like to thank Dr. David Eichten for coming, and I'm hoping we'll see him back for another show. Actually, we just got finished doing a separate show on a product called Lipogems, and you might want to see that one too.
Thank you.
At Joint Implant Surgeons of Florida, Dr. Eichten offers state-of-the-art orthopedic care. Dr. Eichten gives special attention to each patient's condition. He listens closely and offers individualized treatment plans, including physical therapy, injections, regenerative medicine treatments, and surgery. Our patients receive a high level of expertise and service which is unparalleled in any other orthopedic practice. Find out what sets us apart and where your new joints will take you. Take it from one of our patients.
It's been a little over a year since Dr. Eichten replaced my right hip. In 7 to 8 weeks, I was golfing and enjoying other outdoor activities. Dr. Eichten and the staff were great to work with, and I'm extremely pleased with the results.